Welcome back. I'm Linda Resnick. I'm the Principal Investigator of Learn and Professor of Health Services Policy and Practice at Brown University and a Research Career Scientist at the Providence VA. I'm very pleased to be moderating this session on decision support tools. I know that we had a few problems with the poll, and we may be trying to revise it, and we'll relaunch it at another time. So thank you for your patience. So in this panel, each presenter will have 10 minutes discussing their experiences developing infrastructure. And after the three presentations, we will have a question and answer period. You can begin submitting your questions using the Q&A feature in Zoom as the panelists are speaking, and we'll address them after every panelist has presented. And I just want to point out that panelists can't use the Q&A feature. We have to use the chat feature. So if other panelists have questions, you can use the chat. So I'd like to begin by introducing our first panelist, Deb Murphy. Deb, please turn on your video, audio, and share your screen as I introduce you. Deb Murphy is a senior project manager at Spaulding Rehabilitation Network. She has been an integral part of the Spaulding Rehab Hospital, where she has made significant contributions to patient care and rehabilitation services. Throughout her career, she has held various key roles, demonstrating her commitment to the field. Notably, she served as the admitting director at the Boston Hope COVID Field Hospital, where she played a pivotal role in coordinating admissions and ensuring the smooth flow of patients during the most challenging times of the COVID-19 pandemic. So Deb, please begin.
Thank you so much for having me. I'm very honored to be here, and kudos to the folks out in Intermountain who will be getting Bob McCall. I also reported him, and he is an amazing leader. So to start with, I'm talking a little bit today about the Spaulding Equity Dashboard. I'm going to walk you through the what and the how and the why of the creation of our dashboard and what our next steps are. To start with looking at racial inequities of access to care, the Brigham and Women's looked at heart failure patients admitted to the Brigham over 10 years. And if the patients were Black, Latinx, a woman, or over 75 years of age, they were more likely to be admitted to the general medicine service rather than the cardiac service. You can see here from the outcomes that folks that were admitted to general medicine with a heart failure diagnosis had worse outcomes. 27% of those patients were readmitted within 30 days. And looking at the African American population, if an African American was admitted to general medicine rather than to cardiac service, they were 3% more likely to die within 30 days, a pretty startling finding. I also wanted to show what we look like in an outpatient setting. This particular study was done at the Boston Medical Center, and it was looking at patients that had MassHealth. MassHealth is Massachusetts Medicaid program, and looking at patients' access to physical therapy following an ACL repair. If a patient had MassHealth, there were 43% fewer clinics that would accept that patient. Even if that patient was accepted, they had a longer waiting time. So if you're thinking about all of us out here that are therapists, what could happen in that time? Probably worse outcomes in mobility and range of motion. Following the unrest after George Floyd's murder, Mass General Brigham started looking at ways to reduce health disparities. They're looking at the workforce, and they're also looking at patient care. A few of the bullets here are some of the things that they're looking at doing: improving collection of race and ethnicity and language in clinical data. And I think that that's an important one to keep in mind as I go through the rest of the presentation. Eliminate racialized medical practices, increase access to interpreter services, and address disparities in inpatient, outpatient, and also in the primary care practices. The Joint Commission is also looking at ways to reduce healthcare disparities. Lynn had touched on this in her presentation before. So looking at health-related social needs, providing information about community resources, identifying healthcare disparities in the patient population by looking at quality and safety data, developing an action plan, and taking action when those goals aren't achieved. Next thing I wanted to look at is the why and the how. So I found this really interesting. So if you look at how much more quickly visually you're able to process information, it's 60,000 times faster if you're looking at a visual rather than a text. And then I love this this other graphic here that was done by Microsoft back in 2013 that essentially says that humans have a shorter attention span than goldfish. So 8 seconds, and this was done 10 years ago, and I can only imagine what that is now. I've got 17-year-old twins, and I know that I go upstairs and see what they're doing, and they're on their Xbox, and next to them they have their phone watching YouTube videos at the same time. There's so much bombarding of data right now that it's important to be able to get that information as quickly as possible to the end user. As was mentioned in my bio, I had the fortune of being the admitting director for the Boston Field Hospital, Boston Hope. So you can see here the first time that I think we as a network, Mass General, Brigham, and Spalding specifically, looked at dashboards was with Boston Hope. And Boston Hope was created at the Boston Convention Center, and it was there to manage the COVID surge. It was done in partnership with Mass General Brigham, with the time was Partners Healthcare, the Commonwealth of Massachusetts, a City of Boston, and Boston Healthcare for the Homeless. This represents the hospital side of Boston Hope. Few things that I want to point out in this dashboard that will be different as I show you our Spalding Equity dashboard is the patient population itself. This is really telling of who was really impacted by the COVID pandemic. First thing here you'll see is where our patients were coming from. They were mostly coming from non-partners hospitals. So it's probably hard for you to see, but Boston Medical Center, the Cambridge Health Alliance, both of their campuses, that section of the city has a large immigrant population. Another section here, and this dot right here is the city of Chelsea. Chelsea was incredibly hard hit by the pandemic. It had one of the highest rates of COVID in Massachusetts. Chelsea is noted for having a large immigrant population, a lot of overcrowded housing, Latinx, and low-wage earners. Although we don't see anywhere here for payer, I know that being at Boston Hope, a lot of what we saw were undocumented patients. So patients that didn't have access to post-acute services anywhere. So Boston Hope may have been one of their only options for post-acute care. And lastly, on the bottom, looking at the demographics of the patient. Again, pointing out what you'll see a little bit later in the presentation is the patient population. This patient population was younger, predominantly male, non-white, and non-English speaking. From that experience, we wanted to create a dashboard for Spalding, looking at our equity and inclusion. This was our first attempt at looking at it. And a few things that I wanted to point out here is that this is static information. So you're just looking at a snapshot in time as to what our patients look like. So whether their race, ethnicity, where they come from, their age, their gender, etc. Another thing that I had mentioned earlier in the presentation was talking about the challenge in getting information. So you can see here, race, there's a percentage of folks that don't want to talk about their race, ethnicity. Also, their disability status. Does somebody have a disability? They're leaving it blank. And also sexual orientation. The majority here is somebody has either not been asked or has refused to answer the question. So important to make sure that we're collecting that data. How we started moving away from a static dashboard to one that told us a little bit more about the outcomes of our patient was to create what was called a wireframe. So this is a PowerPoint slide that pretty much before we started delving into the data, really pulled out what we wanted to see and how we wanted to see it in a few key indicators that we thought were going to be important to look at our patient population. And here you have it in real life. So it's interesting to see what we had as a vision translated into a dashboard for use. You could also hear how the dashboard works is you select a drop down that you're able to change a key demographic indicator. Right here, I have it defaulted by race. You can look at, the average and then how folks based on their race fall on either side of the average line. The color indicates the race in this instance, and the size of the dot indicates the percentage of patients. So you can see here, the biggest dot here is white, and it's about 77% of our patient population. This equity filter on the side allows you to drill down a little bit more specifically in some of the different areas. So say, for instance, you want to see what the racial distribution is of married women over 70, how they, fare compared to each other based on race. So now I've pulled that out, and you can see, interestingly, that the population drops or actually increases to about 90%. And I'm going to stick with Caucasian women. So they stay longer, are less likely to be discharged to the community, do a little bit better mobility-wise, and are right about average for self-care. So you're able, based on specific demographics, you can filter out the dashboard to really get a sense of what those patients look like. We also wanted to see how our patients did over time. So this was our wireframe looking at their length of stay, discharge community, change in self-care, mobility, et cetera, how the patients did over a certain period. So if we had any interventions, is that making a difference in how those patients are doing over time? And this is how we have it documented in the live dashboard. Here, it's interesting to see when we had taken the wireframe, we're hoping to be able to visualize all of the races together, but when you put folks together, it just got really too busy to be able to identify. So what we have right now is a pop-out looking at different racial groups over time. And then I use the same filter looking at age, marital status, and gender, and you can really, here you're starting to get into the differences in how people are, moving through the system and if we're making gains or where we have work to do. One thing I also want to point out here are where our next steps are going to be is kind of the percentages. So you're looking at Asians, and 100% of women, married women that were Asian over 70 went home. But what is that in terms of a patient population? How many patients is that actually? And then lastly, where we're going next. So one thing that's important to look at, I displayed and we had averages. Does averages make sense? So is an average important, or is it important to create benchmarks? And then the next question is, whose benchmarks? Do we say an internal benchmark based on the internal patients? With UDS, we're looking at the region and the nation. Is that what we use for a benchmark? And also, community, if we're looking at Massachusetts. So what percentage of Massachusetts population may be African American versus how many African Americans we have in our patient population? That's important to look at. As I had mentioned before, how do we weigh patient populations? If you have one patient that has a certain demographic, that's going to be more highly weighted than if you have a large group. So how do we adjust for those differences? And then very importantly is, how do we understand the demographic disparities of patients who don't even come to us, if they're not referred to us, if they don't have insurance approval, or if they don't have, we're not contracted with them and where they live, how that is impacted in our outcomes. and then the use of best practices to increase accurate and complete patient data. As I showed on our initial social inequities, there have a lot of gaps in terms of what patients are reporting for themselves, or if they're not being asked the questions on entrance. And we also want to make sure that we're looking at impacts by payer. I started out talking about a study looking at mass health patients. So are we impacted by payer? And then I'm sure I'll be preaching to the choir in this audience the impact of managed Medicare. Are we able to take managed Medicare patients? I know that's a big challenge. And is that going to impact outcomes? And then once we're able to do all this, who are we sharing this dashboard with? How do we share it? We have a lot of like ADC dashboards that are pushed out to different groups. Are we going to use that same method to distribute this dashboard? And how do we understand what the data is telling us? Why is it happening? And how do we make the information actionable to affect change? So thank you so much.
Thank you, Deb. That was a wonderful talk. And I know I'm sure we have a lot of questions about that. So I encourage audience members to begin submitting your questions, and we'll address them all following the panelists' presentations. And now I'll introduce our second panelist, Jason Benichuk. Jason, please turn on your video, audio, and share your screen as I introduce you. Dr. Benichuk is a clinical research scientist at Brooks Rehabilitation and a research associate professor in the College of Public Health and Health Professions at the University of Florida. His research interests focus on identifying predictors of musculoskeletal pain and disability outcome, risk stratification models, psychologically informed practice, implementation science, and health services research. His work has been supported by the National Institutes of Health, PCORI, COSTAR, the Center for Health Services Research and Training, and the Foundation for Physical Therapy. So Jason, please begin.
Thanks, Linda, and thanks for the planning committee for the invitation to speak at this event. I had a great time last week with listening to the speakers, and keynote today was great. So thank you. So in thinking of the title for this talk in regard to the application of decision support tools, I really wanted to kind of think about the difference between dashboards that are passive in nature as opposed to active, because as you all know that have kind of gone through this process of developing dashboards, creating dashboards, and then actually using them in a system, a lot of work really goes into changing the behaviors of clinicians, for example, in terms of just collecting data. We could have our dashboards that look nice and fancy and people look at them. We like to incorporate them into presentations, but are we actually using them to inform clinical decision making and really answer some of the questions that a lot of the other speakers really addressed? So I kind of look at us at Brooks Rehabilitation as kind of being in the mid stage, right? We're not really in the early stage, because we developed the dashboards. We thought about the measures that needed to go in to kind of reflect the dashboards, but we're also not at the advanced stage in terms of really using this information, really using these dashboards. So I'm going to talk a little bit about our journey at Brooks Rehabilitation as well. So where did the title come from? When I was kind of thinking about this and developing it, for some reason, I was also thinking about what we were going to be doing the next day, which was actually going to the beach. And I kind of thought about that in terms of the title. So in terms of the passive creatures, right, we could think at the beach in terms of something like this nice sea turtle that kind of just goes along its merry way looking for food and isn't really passive in nature. Or we could also think about the reef sharks that we see here, right? They're very active, they're very dynamic, and in terms of how they are different from the sea turtles, I think we can all agree that they are probably very different. So in terms of the journey, right, the journey that we've been on in terms of dashboards at Brooks, right, specific to one division, those of you that were lucky enough to participate in the forum last week, Dr. Mindy Maness talked a little bit about Brooks and kind of described our healthcare system in general. This talk and my focus is really going to just really focus on the outpatient division. So I'm going to kind of talk about, our journey in terms of building those dashboards, but also really linking it to last week's presentation in terms of developing the infrastructure. So this is a slide that Dr. Manus showed last week. And again, my focus is really going to be on the outpatient therapy and services. We have just over 50 outpatient clinics in Florida, predominantly in Jacksonville, but we also have many outpatient clinics in the Orlando region. We have several in the Tampa region, as well as the regions between Orlando and Jacksonville. So this is really part of our journey. When did all this really start? It really started back in 2011. And at this time, I was either at the very end of my PhD training at the University of Florida or very, very close to graduation. And I remember kind of presenting this idea to leadership at Brooks in terms of standardized collection of outcome measures. And what we did in terms of how we presented this to leadership is just before that, we kind of assessed clinicians' behaviors and beliefs associated with outcome measure collection. And we asked them basic questions about their general use, their feeling, what have you, about that. And I think some of the information that we gathered from those early surveys really helped inform that, in terms of barriers and facilitators, clinicians were really interested in using outcome measures. However, I think even similar to some of the findings we may have today, they were really asking for more knowledge and really for more direction in terms of how to use the outcomes to inform their clinical decision making. We also had to select what outcome measures we were going to use in our data collection system. So it wasn't somebody like me just coming in as the researcher saying this is what we must collect. We kind of spread up in groups and we kind of sent the groups on their way. We had a group that was focused on the cervical spine, the lumbar spine, the upper extremity, the lower extremity. And I gave them about 6 weeks to go off and kind of peruse the literature and then come back. Let's meet as a group and let's compare what I think we should be measuring. And you tell me what you think we should be measuring. And we basically came to agreement on every measure except for one. So that was a pretty neat exercise. That took some time though, okay? In 2012 is when we really started developing and beta testing the dashboards. And you'll see 2012 through 2014 is in red. And the reason it's in red is because that was the time that at Brooks Rehabilitation, we were participating in a bundled payment project. So just like some of the speakers last week addressed, when you're in a health system and projects like this are going on, those projects are often prioritized. So needless to say, this project related to the outpatient dashboards kind of got bumped pretty close to the bottom of the list. So it took us several years to kind of develop and beta test. We then pilot tested it in 2015, and I was fortunate enough to, after graduation, win a K-12 award. And like our keynote speaker last week talked about from Intermountain, I actually participated in the Intermountain ATP program. And my project for that program was really focused on a pilot project with just one of our outpatient clinics, and it was really focusing on collecting outcomes. We then used that data. We continue to enhance the dashboard. We officially rolled it out to all of our outpatient clinics in 2017, and at the time, it was just above 40 clinics. And again, this is really an iterative process. And what I mean by that is our end users, our clinicians continuously give us feedback of things they like and don't like. And you'll see in a few slides some of the differences over maybe a 5-year period and what our dashboard used to look like compared to what it looks like now. In 2019, just before COVID, we started monthly communication. So our leadership in outpatient really routinely communicated with the outpatient division on a monthly basis, right? Because we had to start somewhere, and that place was really capturing outcomes. Because in the past, we weren't collecting them at all. Maybe 10% of the patients we were collecting them on. We had to start collecting them, okay? And until we really collected data from a vast majority of the patients that walked in our outpatient doors, we really couldn't start looking at the data. So a lot of time was spent on changing the behaviors and really collecting data. Just after COVID, we established communities of practice, and you see some common themes here The Intermountain Group was very influential in terms of really how we kicked this off even in 2011. I'm fortunate enough to work really closely with some of those folks, and they were kind of the guiding vision in terms of what we envisioned our system to be. So I appreciate their support for that. And then just recently, we were able to meet with clinics that were doing very well compared to others in terms of outcomes overall. And we really wanted to kind of ask them some questions in terms of, what are they doing, right? How are they using the outcome measures? What does their diagnostic process look like for patients with, let's say, low back pain? And then a question, a very basic question, why do they think they were identified as a high-performing clinic for, let's say, patients with neck pain? So we kind of collected that data recently, and we really haven't started looking at it yet. And then I'm going to kind of link this all to my current position with the CoStar Fellowship. Really, where we are here sets us up for nice opportunities to really move from the mid-stage to the advanced stages. So I talked about the pilot project back in 2015, and this is really data from that project. And this really focuses on initial pain intensity assessments, as well as follow-up assessments. And you'll see here, we were collecting before the project started, I think it was 8% when we started. When the quality improvement project started, we really increased our rates up to 70%. And then what I thought was even more exciting is after the quality improvement ended, we actually came up to close to 90%. And as you can see on the right, these were our follow-up assessments, and they'll never be as high as the initial assessments. But again, after the quality improvement project, we did have an improvement. But again, this was back in 2015. This was 8 years ago. 3 years after that, this is what some of our earlier dashboards looked like, and they were fairly basic, right? By month, we look at the capture rates, and then for an individual clinic, we can compare it to the rest of the outpatient division. So the outpatient division as a whole would be on the bottom, and the individual clinics would be on the top. This example shows initial capture rates on the top and then multiple assessment rates on the bottom. So nice information to have, and it looks at opportunities for improvement. These are our current dashboards, which are a lot more elaborate, where we can kind of select by clinic. We can compare it to the whole division, or we can compare it to just clinics of interest. But what's really neat here is we can also do this by month. We also established our target rate. So for intake capture rates, our target is 90%. And you could see just I think this was a month ago or so, as a clinic, this clinic was capturing data for 94% of the patients that came in their door. Okay, as a division, we were just below 90%. We were at 89%. So again, vast improvements from, and this is data from January 2023 through July 2023. If we hover above these rates, clinicians and others can also see the number of evaluations. So for this individual clinic, there are 70 evaluations, and we have other information there as well. Similar dashboard, but this is our follow-up rates. And again, same clinic compared to the rest of the division. Our target rate for follow-up rates is 65%. So again, leadership communicates with the rest of the division in terms of the capture rates on a monthly basis. This is a snapshot of our dashboards for success rates, and we can toggle to kind of look at efficiency in terms of the number of visits. And here you see kind of a difference between 3 to 8 visits as opposed to 3 to 12 visits. And then again, where are we, right? I think we're still at the mid phases, and where we're going is really trying to improve communication and relationships with our informatics team to move forward. So thank you.
Thank you so much. And I really wish we had more time, but we have another panelist I'm excited to hear from. I encourage you, Dr. Dan Norvell, to please turn on your video, audio, and share your screen as I introduce you. Dan Norvell is a senior research epidemiologist in the Center for Limb Loss and Mobility at VA Puget Sound Healthcare System, and a research associate professor in the Department of Rehabilitation Medicine at the University of Washington. Dr. Norvell started his career as a physical therapist in the U.S. Army and later received his PhD in epidemiology from the University of Washington. He's currently a principal investigator at the VA Center for Limb Loss and Mobility. And his research focuses on veterans with limb loss and racial and gender disparities in amputation level and prosthesis prescription. So please begin.
Thanks, Linda. Thanks for the invitation to come speak at this forum. I'll be talking about the AmpDecide clinical decision support tools, where we've taken the science that we've done and actually translated it to point-of-care tools. None of the authors on our projects have a conflict of interest, and a lot of this research has been funded by VA RR&D grants. So as Linda said, our focus is on veterans with limb loss, primarily due to vascular disease, with the aim of trying to assist in amputation level decision-making as well as prosthetic prescription. I'm going to focus on amputation level decision-making today. And to give you a little bit of background on this, I'm going to show you some data from the VA Surgical Quality Improvement Program database over a 10-year period. These data are stratified by major VA region, as you can see, and it represents incident amputation or first-time amputation at the transmetatarsal level or higher. And if we look at the South, we see that over that time period, the rate of transmet or partial foot amputation was 14%. Compare that to transfemoral amputation was 41%, so a big difference. If we contrast that with the West region, the rate of transmets double and the rate of transfemoral cut in half. Why the difference? Why the disparity? Even after we adjust for other factors and comorbidities, we still see these differences. We're also seeing these differences by race and by geographic region. So it's unclear what's going into the decision-making process and if patient preferences are being taken into account. Some other interesting trends that we've seen, these are data from the very large database within the VA we're fortunate to have, the Corporate Data Warehouse, 17-year period. You can see back in 2005, 11% of the incident amputations were at the transmetatarsal level, and this is over tripled over that period of time with a comparable reduction in transtibial and transfemoral amputations. And the question is why? What's the benefit of a more distal amputation, and is there a cost? Well, we know that providers and patients are managing several risks and benefits to these amputation levels. The literature would suggest that a higher level amputation, especially at the transfemoral level, is associated with a higher risk of mortality. More distal amputations, especially at the foot, often associated with not healing or need for a reamputation. However, those more distal amputations lead to a higher likelihood that the patient will walk again. And we know that walking again is the single greatest determinant of a lower limb amputee's quality of life after amputation. And so the question is there a cost to this limb preservation? So I'm going to use the same data from the VASQUIP data set, over 7,000 incident amputations broken down by amputation level. In that first year after that amputation, 24% of these patients had an amputation or a reamputation on the same side. And if we stratify by amputation level, here you can see the highest risk was in those that had a foot amputation, followed by a transtibial, and then the lowest risk in a transfemoral patient. However, these are population averages, as has been discussed earlier. So we're really trying to move into this area of personalized medicine or personalized rehabilitation. And with the data that we really have the power to do that. So I'm going to show you an example with the same data set here. These are cumulative hazard figures showing the risk for reamputation over the first year. And so the lowest risk group is the transfemoral group, followed by the transtibial group, and then the highest risk group is that transmetatarsal group. If we drill down on that high risk group, we see that the risk differs by the presence or absence of other factors. So the low risk group are those patients that have PAD diagnosed by an abnormal ABI score, but no diabetes. The next highest risk group is those with diabetes, but no PAD. And the highest risk is in patients with both PAD and diabetes. And so each patient is unique. And so the risks are really dependent on the whole host of personal factors that they have. And that's what led us to the development of the AMPREDICT model. Several years ago, we started this process, taking into account a whole host of predictors, demographics, mental health factors, comorbidities. We published the first AMPREDICT model on mobility in 2017. We followed that with the AMPREDICT reamputation model, and then finally the AMPREDICT mortality model. After publishing, we thought, okay, we've done the work, we've disseminated the results, move on to some other research. The problem is we were getting contacted by several providers around the world asking us, how do we apply these models clinically? We have these coefficients. What do we do with this? And so it caused us to stop, pause, and think about that. And we thought, we ought to create a basic risk calculator using an Excel file. And so we did that, and we shared it, and people really, really liked it. And so we had a light bulb go off. We need to develop a decision support tool. And so we were fortunate enough to get more VA funding to develop the AMPredict decision support tool, which included both the development process, usability testing, qualitative interviews, and so on. I don't have time to get into that process, but we do have a publication on how we went from A to Z in the development of that tool. So where are we today? Well, we have the AMPredict clinical decision support tool, and that's based on the AMPredict models, the science behind that. We've also developed a parallel set of patient decision aids, which we call the AMPDecide patient decision aids using the International Patient Decision Aid Standards. These are more presented in layman's terms to the patient. Those that do have the option, perhaps between a couple of levels, to understand the risks and benefits, to be able to go through a values clarification exercise. The whole point, though, being to bring the provider and the patient together, armed with this information in a shared decision-making fashion, to make a decision about the best amputation level that meets their priorities and preferences. And so if you go to the ampdecide.org website, and I'd highly encourage you to do that because we really love feedback, you have the option of that AMPredict risk calculator. You also have the option of the AMPDecide patient decision aids. I have not a lot of time, so I'm just going to do a quick demo of the AMPredict decision support tool and encourage you again to visit the aids as well to see the patient's perspective. So I'm going to go ahead and click on the website here, and hopefully it'll bring it up pretty quickly. Okay, and as I said, you have the option of the AMPredict decision support tool or the aids. So I'm going to go into the tool. And the first thing that it asks, or basically a disclaimer that says this is not intended to direct treatment. It's supplemental for the provider to share with the patient to make a decision. So if you click on that, when you go into the calculator, if you've used it before, you can go right into that calculator. However, if it's your first time and you want more information, you can learn about patient eligibility. Patients are eligible if they're 40 years of age or older, has to be a vascular amputation at the TransMet level or higher, and we have excluded patients that have these real severe diseases that often lead to high mortality rates early. The other thing that we found in the usability testing and the qualitative work were some of these important characteristics, provider and patient benefits. The first is that providers do feel that this will help them in that shared decision-making process. Patients felt that it will help improve their expectations and knowledge about their future rehab. And then finally, facilitating communication between providers. And this is not just for surgeons, it's really for the rehab team to come together to talk about the predictions, really think about the best rehab plan for that patient, and also disposition planning. So I'm going to do a quick hypothetical patient here. And let's say as we start with demographics, these are all the inputs from the prediction models. Let's say this is a 67-year-old male who's Black, who's married and has at least a high school education. And then we move into the comorbidities. Let's say this patient does not have congestive heart failure, is not on dialysis, does have diabetes, does not have a history of revascularization on the same side, does not have COPD, and has not been treated for anxiety or depression. We then go into lab values and meds. Let's say this patient has a BUN value of 100, a platelet count of 150,000. Did I get that number right? Let's say the white blood cell count is not above 11,000. That would be indicative of an acute infection. An EGFR value is not less than 15. That's indicative of kidney failure. And they're not taking outpatient anticoagulants in the last 3 months. And then finally, health factors. Let's say he has a BMI of 30, currently not a smoker, does not report the misuse of alcohol. And in terms of functional status in the last 30 days, we'll say this patient's partially dependent. We have a definition of each of those levels here. And then finally, this patient rates their health as fair. We hit submit, and it takes us to the first risk estimate. So again, same patient, 3 different amputation levels. You can see their risk of dying in the first year is 30 to 40%, regardless of the level of amputation. And the difference between amputation level is not large. And that's because it's really comorbidities that are conveying that mortality risk. So once you see that, you can go to the Reamputation Mobility tab. And here you see that if this patient undergoes a transmetatarsal amputation, they have a 33% chance of having to have another amputation versus half that risk at the transtibial level and very little risk at the transfemoral level. Contrast that with their mobility, higher probability of walking again at the transmet level, 60% at the transtibial, and then a low risk at the transfemoral level. So you can see here, you could compare and contrast. A patient may be willing to take a high risk for reamputation to have a higher level of walking again. But they may say, I don't want to have surgery again, and actually be able to still walk at a 60% chance. So you can play around with that calculator when you have time, and I'm almost done now. I see Linda there. And so that's the calculator. These are some pictures of the decision aids. And finally, my last slide, we are currently funded to actually integrate the tool into the electronic health record. This is a screenshot within the VA. The predictors are all auto-populated and you get the risk right on the screen. So you can make a quick point of care decision and share it with the patient. That concludes my time.